This I added as well because our friends at the FDA just recently, in the last couple of weeks, changed the labeling for all opioids. So there's a new label, a new black box warning. And these are the updated CDC guidelines from late last year. So I wanted to review both of those with you quickly. And our friends at the CDC, when they did this, they have 4 major categories and 12 specific recommendations. So the major category, first one, determining whether or not to initiate opioids for pain. And they have 2 bullet points here. Non-opioid therapies are at least as effective as opioids. And there's some fascinating studies out there done in the emergency room, done post-operatively, to suggest that at least in the emergency room, acetaminophen plus ibuprofen is better or at least no less effective than oxycodone with acetaminophen, hydrocodone with acetaminophen, or codeine with acetaminophen. The efficacy is just as good. And the data post-operatively is fascinating that most patients post-op will not need more than 2 to 4 or 5 days of opioids. And yet most of them go home with a much larger quantity than they need. And what do you think happens to those opioids when they get home and they quit using them? The kids take them. Where do most people keep their medications? Medicine cabinet, or in a cabinet in the kitchen? And would it be easy for somebody to go into the bathroom and take the Tylenol or aspirin bottle and put those tablets in the bottle and take out the opioids? Would anybody ever know? They'd never know. But what could happen to that young person who took them? They could die. Now, how would you feel if that was your opioid they got and you killed your son or daughter or your grandchild because they got into an opioid that you had that was left over from when you had surgery? We really need to get these guys out of the house. Once you don't need them, don't keep them for a rainy day, because they're like keeping a loaded gun in the medicine cabinet. And one dose, depending on the person who took it, could be a lethal dose. It really is that serious. And we really need to pay attention to it. So we should not encourage the use. And the good news is we're seeing less and less prescribed opioids, legal opioids. The manufacturers have come under fire and have been sued and are reducing the amount they make. The wholesalers have been sued, and they are much less likely to continue to supply it, especially in large quantities. They're looking at it much more closely, making it more difficult, making sure you're not a pill mill. The pill mills have been mostly shut down. So where are most of the opioids that are in the community coming from today? From the street, and not from prescription, but they look like prescription. They're counterfeit. And that's even worse. Because what's in the counterfeit opioids? Fentanyl, or now tranq, or carfentanil. It's even more potent than fentanyl. And you don't know what you're getting. Monday of this week in Charleston, South Carolina, on the same, just down the street from where I live, the DEA and the Sheriff's Department, local police department, confiscated 2.5 pounds of pure fentanyl. You know how many people 2.5 pounds of fentanyl can kill? Over 500,000 people with no problem, and some left over. One person had 2.5 pounds of pure fentanyl in their possession. It is. And in fact, when the police went in, they had to go in with gowns and everything, the hazmat stuff on, because no telling what was there. Many can be absorbed through the skin. You can absorb it through what you inhale. It is lethal. And it is happening more and more. And it's cheap to make. It's easy to make. So it's coming in from China. It's coming in from Mexico. People are cooking it up, and fentanyl is everywhere. So the first one, at least as effective, non-opioids, preferred for subacute and chronic pain. Even chronic pain they're preferred for. This is, again, the CDC guideline from last fall. Andy? Where did Andy go? It's not moving again, Andy. I don't know what I did. Your little clicker's not working. I'm glad you're here. It forgets. Oh, now.
Now it will go.
Okay. All right. Thank you.
Does it work?
Yeah, I think so.
It forgets.
Yes.
I don't know why it forget.
You don't know why it forgets. It's not been taking opioids, has it? Number two, the big bullet is selecting opioids and determining opioid dose. When starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of extended release. Extended release increases the risk of overdose and death compared to immediate release. Neither one is safe, but immediate release are safer than extended release. And prescribe at the lowest effective dose was bullet point number 4. Patients already receiving opioid, clinicians should carefully weigh benefits and risk and exercise care when changing opioid dose, especially when increasing it. And it's most important, especially with the longer acting opioids like methadone. Methadone's got a very long half-life of upwards of 100 hours. And it doesn't last that long for pain, but with that kind of half-life, if you start increasing the dose too frequently, you're going to see that accumulation continue for up to 5 half-lives. So this is going to be more than a week. You're going to still be increasing the dose. Even though you're taking the same amount every day, the levels are going to tend to go up. And at some point, you're going to get respiratory depression. They could quit breathing and die on you. So we have to really be careful about that. Unless there are indications for life-threatening issues such as warning signs of impending overdose like confusion, sedation, slurred speech, opioid therapy should not be discontinued abruptly because they're going to withdrawal. We want to taper them off, but we also want to taper them up slowly as well. So when you're using opioids, we taper slow up or down. Deciding on duration of initial opioid prescription and conducting follow-up. Prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. Post-op, it's generally not more than 5 days. And many states now have, for immediate release opioids, opioid naive patients, you can only get a 7-day supply or a 10-day supply as the max you can prescribe. And that's not a bad thing. That's a good thing. They don't need a bottle that has a 30-day supply because they had open heart surgery. When I had my triple bypass and was opened up, I took 2 doses of my hydrocodone when I went home. And I had a bottle of 30. But I took 2. So do we need to give somebody 30 tablets when they leave the hospital? And in fact, most of them are there for a couple of days afterwards. They're getting opioids while they're in the hospital. And then they send them home with a large enough supply to get them through a couple of weeks, and they don't need them. We don't need to send them home with that many tablets. And if they need them, they can go back and get them. You can give them another prescription. You can call your doctor and say, I need to have this. And we can get another prescription for you. It's probably not worth it because what are people going to do? They're going to leave them in the house, and that's where our kids and grandkids are getting the drugs from. Number 7, clinicians should evaluate benefits and risks within 1 to 4 weeks of starting opioid therapy for subacute or chronic pain and regularly evaluate benefits or risk of continued therapy. And what are the side effects we need to educate patients and caregivers on related to respiratory depression? We all know about the constipation. We give a bowel regimen but do we educate enough on the things that could cause somebody to lose their life? Increased sedation, decreased arousability, a little bit of cyanosis. Those are the common things we see when we get too high a dose of opioids. And that's when we need to make sure they've got the Narcan around. The naloxone is really important for these patients. And I personally would say that anybody who gets 50 morphine equivalents a day or more of any opioid, they better have Narcan at the bedside or available at all times because they're at risk. As the dose goes up, the risk goes up dramatically. And I think the minimum that I would suggest before I mandate naloxone, and I'd like to have it before that, is 50. And a lot of states will not mandate opioids as you get up around 100 or 120 morphine milligram equivalents, and that's way, way too high. Very few people need that kind of opioid dose unless they're in hospice, they're end-stage malignancy. Assessing risk and addressing potential harms is the next big bullet point. So recommendation number 8, evaluate risk for opioid-related harms and discuss the risk with the patient. If you take opioids for more than a week, you more than double your risk of getting addicted or hooked on opioids. You get at least one refill, you more than double your risk. So the higher the dose, the longer you're on it, the greater your risk. And it doesn't mean you have an addictive personality. The drugs can induce it. That euphoria that you can get, if you get it, can lead you to want to continue to take it. And as you develop tolerance, which most of us do, you're going to want to increase the dose. And all those are things that are going to make these things much more difficult and harder to get people off. So the longer you're on it, the higher the dose, the greater the risk. And why you can't just abruptly stop it unless you absolutely have to, because you're going to have withdrawal. Number 9, when prescribing, review the patient's history of controlled substances. Make sure you search using the State Prescription Drug Monitoring Program, PDMP, to determine whether the patient receiving opioid doses or in combinations to put the patient's higher risk for overdose. What's the number one risk combination? Opioids plus what? Benzos. Way, way up there. Benzos depress respiration. They're additive. Another one that's additive is alcohol. Any CNS depressant is additive to opioids. Gabapentin is additive to opioids when it comes to these effects. So you really need to watch those, and I'll show you more on that in the FDA label in just a minute. Oop, jumped ahead too far. Come back. Go back. So, whoop. Number 10, consider the benefits and risk of toxicology testing. So, drug level testing. So that's something else that's there. We want to drug screen. Caution when prescribing opioids with benzos concurrently. Number 1 risk for the combination. And number 12, offer or arrange treatment with evidence-based medications to treat patients with opioid use disorder, buprenorphine. We now have removed some of the restrictions on buprenorphine, the numbers you can treat, and ease to get it. So that's becoming easier to use because it is less likely to lead to respiratory depression and unintentional, intentional drug overdose. It's not benign, but it's safer. So we're making it easier to get. So that's the CDC 12 recommendations from last year. Here are the new ones from the FDA. FDA safety communication as of April the 13th. update the prescribing information for both immediate and extended release opioids. All opioid pain medications will now contain these things in their label. So this is new for the labeling, okay? All of them. And that's the link to the FDA press release where they put it in. It says, acute pain conditions treated with outpatient setting require no more than a few days of opioid pain medication. This may include occurring with a number of surgical conditions or musculoskeletal injuries. Again, 3 to 5 days, with the exception of back pain and pain for neurological surgery, are the only one that may go out to 10 days. Every other surgical procedure, if you look at the data, is 3 to 5 days in general, is the amount of pain that they treat with opioids for 3 to 5 days. So more than a week is not necessary unless it's back surgery or it's somebody with neuropathic pain. And even then, these drugs are not that great. Come back to that. So this is life-threatening respiratory depression, addiction, abuse, and misuse. Those are part of the black box warning. And the accidental ingestion, there was no change. The respiratory depression, there was more added. Risk from concomitant use of benzos or other CNS depressants are listed here. Result in profound sedation, respiratory depression, coma, and death. And reserved concomitant prescribing of the opioid plus benzos or other CNS depressants where alternative treatments are inadequate. So they put that in the black box warning now. So these are all part of the black box warning. Neonatal opioid withdrawal syndrome now. And so if mom's taking opioids when that newborn is treated, the neonatologist needs to be there and be aware that mom was on an opioid, because that baby's going to be born and go right into opioid withdrawal. So again, if we can get away from it, we'd rather not use opioids during pregnancy. Opioid analgesia risk evaluation, REMS. Healthcare providers are strongly encouraged to complete a REMS compliant education program. The New England Journal of Medicine has one that you can sign up for free and go through to counsel patients and caregivers on serious risk, safe use, and the importance of reading the medication guide with each prescription. The other thing that's really important is patients need to read the labels on the bottles. And my wife's not with me, or this would cost me another pair of shoes if I were to tell you this, but she's not here to hear it. So just don't tell her, okay? Because every time I bring this story up, it costs me a pair of shoes or a new handbag or something. Yes, she does. She likes expensive shoes. Melda Wirt's what I call her. But my dear wife of 54 years, she's done this with 2 different medications because she doesn't read the bottles. When my daughter was in school, my daughter had attention deficit disorder. She had some methylphenidate, some Ritalin. My wife was on Synthroid. My wife went in and said, oh, that's my Synthroid. Took the bottle out and took it and didn't read the label. It was methylphenidate. And she couldn't sleep. She stayed up all night cleaning. That wasn't so bad. The next 2 are worse. Anybody know what atorvastatin 10, how it differs from Ambien 10? They look the same. White tablets, oblong, same shape, same size. Well, one morning at the time she was still teaching middle school, and she would get up earlier than I would, and I went to get up, and the bathroom door is still closed, and she's still in there, I think. So I try to open the door. She's on the floor behind the door. I thought she's had a stroke. Something bad has happened. So get her up. She's not making any sense at all. I take her to the emergency room. They check her out. I can't find anything wrong with her. And while she's there at the emergency room, she wakes up and said, how did I get here? What happened? I don't know anything. I don't remember anything. I remember getting up this morning to go to school, And that's the last thing I remember. And she took a 10 milligram Ambien instead of a 10 milligram atorvastatin. Okay?
Good.
But it didn't just happen once. She did it again. My wife. And every time I tell the story, it costs me. But because she doesn't read the label, she just picks up, it looks like her med, she takes it. She needs to read the label, make sure she's got the right medication. And now I make sure she puts everything in a pill box. And luckily, we don't have any Ambien in the house. We don't have any methylphenidate in the house. She does still take Atorva, but it's a higher dose. So it's the larger tablet, the 40 milligram instead of the 10. And she still takes Synthroid, but she's got them all laid out in the pill box like I do. And I've not had a problem since. But when she was taking them out of the bottle in the morning, I never knew what was going to happen. And it was like scaring to me. I thought something really bad had happened. And it was just the Ambien instead of the Lipitor, not once, but twice. Happened the same way. So we need to pay attention. Opioid analgesic risk, the mitigation, and this next one is a new bullet that's not been there before. And this is under warnings and precautions, not the black box. Opioid-induced hyperalgesia or allodynia. What's that? Taking opioids increases your pain, doesn't reduce it. And that has now been reported with increasing frequency everywhere. So people, as they titrate the dose up, the pain can get worse as they increase the dose, not better. So that's now been added based on case reports. And this is actually from the FDA, but it says paradoxically cause an increase in pain or an increase in sensitivity differs from tolerance. Increased levels of pain and opioid dose increase, decreased levels upon opioid dose decrease. So reducing the dose may improve their pain rather than increasing the dose. So this is relatively new. It's been talked about for about 10 years, and now it's in the labels under precautions for every opioid as of this month. So that's new. Okay. Only if there's no evidence of underlying disease progression, opioid tolerance, or withdrawal or addictive behavior, then you need to think about opioid-induced hyperalgesia. Okay. So increasing the dose is not always a good thing when it comes to greater reductions in pain relief. Again, this is that same data. This is again from that. If a patient is suspected of experiencing opioid-induced hyperalgesia, carefully consider appropriately decreasing the dose of the opioid or opioid rotation, switching the patient to a different opioid moiety at an equivalent or lower dose, looking at morphine milligram equivalents. And here's the data that they put in their publication based on 38 cases with long-term use, 8 cases short-term use. That's from their FDA reporting system. And there's a lot more in the literature. The cases involve a range of opioid meds, including most commonly morphine, hydromorphone, fentanyl, and fentanyl analogs. Cancer was the most commonly reported condition being treated. Other possible causes that were excluded, such as worsening of disease, patient reported improvement in pain after stopping opioid pain medications or reducing the dose. So that's something that's important to talk with our patients about. We're going to work through helping you treat your pain, but sometimes the opioids can make your pain worse. That's the take-home message. And by increasing the dose, it could get worse. So we need to know if it gets worse. It's not that we need to increase it more. We may need to back off or change your opioid. Over-the-counter Narcan, nasal spray. It's now OTC, hasn't been launched yet. Don't know what the cost is, but I hear it's going to be $50. for the 2 doses nasal sprays, for 2 doses. That's the rumor. And people are saying we hope it's less than that. That may be too high, may discourage people from buying it. But on March the 29th, the FDA approved the Narcan nasal spray, the 4 milligram dose for over-the-counter use. Opioid overdose, the leading cause of accidental death. Every 8 minutes on average, a person dies from an opioid overdose, and about 40% result from diverted medications. Prescription opioids that get into the hands of somebody else. And the other 60% are the stuff you buy on the street that you don't know what you're getting. And many of those are made to look like the prescription ones. So really be careful, because fentanyl is everywhere. This just shows you the blood levels you get, and it says good, if not better, than giving it sub-Q. So nasal Narcan is the way to go. You squirt it in one nostril, and if they haven't responded, go ahead and use the second dose. And especially we're dealing with fentanyl, you may need higher and higher doses. Fentanyl is reversed by Narcan, but it doesn't come off as easy as the other opioids do. It takes higher amounts, and it's not going to last as long, so you may have to redose. So you can still call 911 and get the system activated, get them into the system. Even after you give it and they wake up, you're going to put them into withdrawal, but that's okay. They're going to get nasty with you maybe, especially if they go into withdrawal. And that's why our fire department, before they give it, they make sure they have the police department there with them. The EMS guys always have the police with them when they come, because I still feed the homeless 2 nights a week in Charleston, and we call periodically. We give them a Narcan, and we try not to do it ourselves unless we absolutely have to. We wait for EMS to come with the police, and they come together. We have the police and them come, and then they take them to the ER, wherever they need to take them. But the police are always there with them, because when you wake them up and they go into withdrawal, they can be really nasty. So you really have to be careful. It's not something we need to take lightly. And I've had to call twice in the last 3 months. Risk of accidental overdose, higher prescription strength, number of morphine milligram equivalents per day, especially above 50, and it goes through the roof. You get to 100 and above. It's very low, less than 50. Have opioids in the house or a household member, you need to have Narcan available. Take opioids with benzos or sedating substances like alcohol, increased risk, got to have Narcan available. You have HIV, liver disease, lung disease, or mental illness, increased risk, have Narcan available. History of overdose, Narcan available, and history of opioid use disorder, got to have Narcan available. So again, with it over the counter, we were able to prescribe it. Most states have pharmacists can prescribe Narcan now in most states, but this is going to increase the availability. It'll be in grocery stores, it'll be in convenience stores as an over-the-counter medication. And there's only the one company that has the brand Narcan nasal spray is the only one that's been approved for over-the-counter at this point. So there's only one that you're going to be able to use for OTC. So Narcan nasal spray, it works quickly. And if you don't get the desired response in 2 to 3 minutes, go ahead and give another dose if you have it the other nostril. Because again, fentanyl is reversible, but it's more difficult, takes more to reverse it. And the sad thing is that carfentanil is probably not likely to be reversed because it's so much more potent than fentanyl. And Trank, the new kid that we're seeing on the street, is not reversible. Narcan does not work for Trank. And Trank is being put in a lot of the street drugs now. So we're going to have more deaths, and they're not going to respond to Narcan. Sorry to say.
That's Zyl's name?
That's it. I'll show you to it, right? Well, this is how to recognize it, opioid overdose. extreme somnolence, inability to waken the patient verbally or upon external rub, respiratory depression, slow or shallow respiration, no respiration, or patient is unarousable, somnolence, meiosis, pinpoint pupils, bradycardia or hypotension, fingernails and lips turning blue or purple, cyanosis. Those are the things that we see in people who end up dying from opioid overdoses. Respiratory depression is what kills you, not constipation. The nasal spray, you get over the counter, and these are the side effects, and they're generally not major at all. And other than putting somebody into withdrawal, or there's no risk for giving Narcan other than the withdrawal you put the patient in. And it will prevent, or not prevent, but treat the respiratory depression unless they're on fentanyl and you don't give enough, or they're on tranq. And this is tranq, xylazine. This is the new designer one that's out there, and its street name is tranq. It's being used to cut heroin. It's being added with fentanyl to some of these street drugs that people are buying that look like prescription opioids. And the scary thing is, it is not reversible with Narcan. Naloxone does not reverse respiratory depression with this drug. The only thing you can do is intubate these people and give them respiration. There is no reversal agent for this drug right now. And it's a drug that's been used in the veterinary practice for a long time. It's a tranquilizer, veterinary tranquilizer, but it's now on the street. It's easy to synthesize, and we're seeing more and more cases, and it does not respond to Narcan. Yes.
Still giving that.
Yes. Right, because it could be, it's mixed with a bunch of things. And fentanyl and is also used in combination with this guy. So it may help some, but if it's due to this guy, fentanyl, you can reverse, you can't reverse this one. And you can see DEA has detected it in 23% of confiscated fentanyl samples in 48 states in 2022. So it's being mixed with fentanyl. So this is a double death. Opioid veterinary tranquilizer, not approved for use in humans, increasing number of overdose, and does not respond to naloxone. The other thing that's interesting, this is from MedWatch, and it suggests 12 samples of naloxone were obtained from public safety agencies that expired or training supplies, including 25-year-old naloxone. It still works. So even though it's out of date, it still works. So don't worry about using it. If it's a life-threatening situation and it's out of date, don't worry about it. You can't dispense it if it's out of date. There's no reason you can't use it. All right. And this is actually suggesting even long out of date, it still works. Okay. So it doesn't deteriorate significantly over time. Questions on the opioids? So those were added, and I've given those slides to Charlene, so they're in the new slide deck. One of the major changes in healthcare that is still not widely recognized are the new asthma guidelines. What do most of you guys, if you're in pharmacy, what do you dispense as a rescue medication? Albuterol? Right? Albuterol, right? Most people are still getting albuterol for rescue. Well, in 2019, that was said not to be what to do. 4 years ago, but it was during COVID. So the message is not out there. And most clinicians and most pharmacists are not aware of this guideline. This is a guideline that's put out and updated every year. It's a joint effort between the World Health Organization, WHO, but it's also between the National Heart, Lung, and Blood Institute, NHLBI in the US. So it's a US and WHO guideline for asthma, and that's the GINA guideline, Global Strategy for Asthma Management and Prevention. And then they also do the GOLD guideline for chronic obstructive lung disease, COPD. Same two groups, okay? So I'm going to show you both of them because they're both updated. This is the 2022, and we should see any day now because National Asthma Day is next Tuesday. Next Tuesday is National Asthma Day, according to the World Health Organization. And they usually issue an update to these guidelines about the same time as National Asthma Day. When I looked 2 days ago, it hadn't been updated yet for 2023. Now, this is their new guideline. This is their algorithm. And let me try and walk you through it. Hopefully you can see it with the light here. And you'll note this one says preferred controller and reliever. This one says alternative reliever with the controller. So this is preferred, this is alternative. All right? Preferred, steps 1 and 2. What's step 1? Somebody with infrequent mild asthma, who we in the past have treated with PRN albuterol, and that's it. No maintenance, no inhaled steroid, nothing else, just as needed albuterol. That was the recommendation until 2019. What was step 2? Mild persistent asthma, we needed to add an inhaled corticosteroid for maintenance and still use your albuterol for rescue. That was step 2. And they used to be separate steps. Now they're combined. And what's it say? Preferred. As needed low dose ICS formoterol. What's formoterol? A long-acting beta agonist or a LABA. It's in Dulera, it's in Symbicort. Okay? And it doesn't say just a beta agonist. There's no SABA, short-acting beta agonist on there, is there? Albuterol's gone from that preferred, right? And that's what most of us are still dispensing and prescribing. Albuterol for step 1 and step 2. And it says ICS formoterol combination. So even step 1, PRN, is ICS formoterol. So it's not scheduled, it's as needed. And it says, as needed, low dose for steps 1 and 2. Even with step 2, when we used to prescribe daily ICS, you can now use PRN. These are wholesale changes in this guideline. Okay? And we're going back to why in just a minute. Step 3 is low dose maintenance ICS formoterol. So you take your Symbicort or Dulera twice a day for maintenance. And when you have breakthrough, what do they treat the exacerbation with? ICS formoterol, same inhaler. And that's off-label. That's not an FDA-approved indication for Symbicort or Dulera, the two that are out there in combination with formoterol. And why do you think it says formoterol, not any LABA? Because salmeterol is the #1 prescribed. It's in Advair. Why do you think it says formoterol instead of salmeterol? Salmeterol is slow onset. Long-acting 12-hour duration, but slow onset. Formoterol is 12-hour duration, but fast onset. It's the only long-acting beta agonist that's fast onset. So the guideline specifically says formoterol plus an inhaled corticosteroid. Doesn't matter which steroid you use. And all the steroids, with one exception, are twice a day, the inhaled ones. Which one is once a day? Arnuity, the one with the orange cap. Arnuity is the only ICS inhaler that is once a day. Why is that? It's still fluticasone. Same one that's in Advair, that's twice a day. It's a different ester. It's a ferroate instead of the propionate. And how do they compare? Ferroate, they're both fluticasone in the body. The propionate's 12-hour duration, the ferroate's 24-hour duration. And what's the difference in potency between the ferroate and the propionate? 5-to-1. 5 times more potent with the ferroate than the propionate. So I'll just give you an example. What are the doses of fluticasone ferroate that are in Brio or Annuity? They're 100 or 200 micrograms once a day of fluticasone ferroate. Once a day, and it's 100 or 200 micrograms. And the only difference in those inhalers is one's got a yellow label and one's got a white label. They both have orange caps. They both look the same except for the label. It's just the only dose that's different is the fluticasone dose. Same thing with Brio with the light blue cap. There's a 100 and 200 microgram of the ferroate, the fluticasone, white versus yellow on the label. The only difference. But how do they equate to Advair, Discus, salmeterol? What are the 3 strengths of Advair? 100 microgram, 250 microgram, and 500 microgram of fluticasone propionate. 100, 250, and 500. The 100 microgram and they're dosed twice a day, right? So they're getting 200 or 500 or 1,000 micrograms a day if they're getting 2 inhalations a day, right? Of the 100, 250, or 500 microgram dose. So the 100 of Brio is equivalent to 250 of Advair twice a day. It's 5 times more potent. And the 200 is equivalent to 500 of Advair twice a day. So the 2 highest strengths of Advair are equivalent to the steroid dose of BID Advair and once a day Brio. Those are equivalent doses. But that's the potency. Duration is twice as long, and the potency is 5 times greater on a microgram basis. So it's the only one that's once a day. None of the other ICSs are once a day. They're all twice a day, except for the ferroate ester of fluticasone. And right now, we don't have fluticasone ferroate with pharmacology. And pharmacology is a twice a day drug, so we're using either budesonide or the Dulera and Symbicort are the only 2 combinations. They're both twice a day ICSs. You go to step 4, medium dose, so you increase your Symbicort from 80 to 160 micrograms, and that's the budesonide or the ICS component. So you double the dose, and you can still use it twice a day, and then still use it as your rescue on top of that. So steps 1 through 4 in the preferred are 1 inhaler for both maintenance and rescue. And it's off-label. Neither of these inhalers are FDA approved for this indication. So either Dulera or Symbicort. And the good news is, hopefully, we will have generic Symbicort by the end of this year. We already have an authorized version from AstraZeneca that's a little less expensive, according to GoodRx, but it's still fairly expensive. So we will see, hopefully, the first true generic of the Symbicort equivalent later this year. That's what the intention is. But then drop down for the non-preferred alternative, take an ICS whenever the SABA is taken. So if you're on albuterol, you also have to have a fluticasone or another ICS inhaler to take every time you use your PRN albuterol. So the alternative is to use 2 inhalers, and every time you take a dose of your albuterol, you also need to take a dose of your inhaled corticosteroid. And we now have an FDA-approved combination albuterol and ICS, but it's not yet commercially available. It was approved in January by the FDA. It's in the process of coming. So you'll see an albuterol combination with ICS, but it's not commercially available yet, to my knowledge. And then your reliever, it still can be your albuterol, but unless you're on a scheduled ICS and taking it every day, you'll still need to add an ICS every time you use your albuterol. But once you start taking your ICS for maintenance and you've taken it, then you don't have to add another dose. Not going to hurt you, but you don't have to add another dose. And that's not the preferred. The preferred is a single inhaler using ICS for formoterol. These are track one is the preferred. Evidence using ICS formoterol as a reliever reduces the risk of exacerbations compared to using albuterol or SABA alone, with similar symptom control and lung function. And under track two, if it's not possible, good adherence with their controller, no exacerbation last 12 months, it's okay, but it's still not as effective as track one. And let me show you what they say. Regular use of short-acting beta agonist albuterol, even for 1 to 2 weeks, associated with increased airway hyperresponsiveness, reduced bronchodilator effect, increased allergic response, increased eosinophils, and it's not as effective. So albuterol, levoalbuterol, is no longer the preferred rescue inhaler. And a lot of people are not going there because of the cost of the drugs like Symbicort and Dulera. And some of the third-party payers are now starting to cover it because the guidelines have gone there. And this is not just the World Health Organization. This is an NHLBI here in the United States as well. And it's off-label, but it's still the recommendation from the guideline, and it's evidence-based. And this is a box warning they put out in 2019. Fundamental change. Treatment of asthma with short-acting bronchodilator alone is no longer recommended for adults or adolescents. That was 2019. And this is 2023. It's still our #1 prescribed drug. So we're slow to learn. Here's some randomized trials in over almost 10,000 patients. 65% lower risk of ER visits and hospitalizations than with the SABA alone, and 37% lower than with daily ICS. So the combination of ICS formoterol reduces ER visits, reduces hospitalizations, and better than ICS alone or short-acting beta agonist alone. Here are some more data with it. Long-acting antimuscarinic should not be used as monotherapy for asthma. So that's your tiotropium, Spiriva. It's approved for asthma. It's a different dose than the COPD dose. It can be used, but it's added as a third or fourth line drug. It is not first or second line. So with asthma, ICS and beta agonists are first and second line. And then you come to long-acting antimuscarinics are no better than third line, added to ICS and long-acting beta agonists. And they may reduce exacerbations a little bit. So again, this is children 6 to 11, preferred again, daily low-dose ICS. And you can use formoterol, as it said down here, into this age group. So Symbicort and Dulera are approved for asthma for chronic management, not for acute use, but they can be used. And you can use 8 to 12 additional inhalations a day for rescue on top of maintenance if you need to. So there's no concern about using too much for most people, but the shorter amount of time they are on it, the better, especially with higher doses, because you will get receptor subsensitivity with regular use of beta agonists. The receptors will turn inwardly. You get shorter duration, less benefit, and you may need to give systemic steroids to overcome that. So there's a problem with people coming into the ER. They've used, I had an example I'll give you of a high school student from our area who was seen at the ER at 4 o'clock in the morning, which is fairly common with people with persistent asthma. And he had gotten his Advair discus refilled 3 days ago and already used 30 doses in 3 days. He was using it as his rescue inhaler with Advair. And when he came in, he didn't respond to albuterol at all. No response, because his receptors were subsensitive. They had turned inwardly, and there was nothing for the albuterol to do. The only way to reverse that is to give systemic steroids, and that'll reset the receptors and make him respond. And the good news is with ICS formoterol, we're using the combination for short acting, and hopefully we won't have to use it that often with a 12-hour duration with the formoterol. So that's one of the benefits you get over albuterol. And this is COPD versus asthma. And there are a lot of, you'd have a question. Okay, if it's just step one, it's PRN. Nope, as needed. You can use it before exercise. It's got good data there. And the combination is better than albuterol when you compare to ICS formoterol. It's longer duration and more effective. And then when they go to maintenance with step 3, they use it twice a day for maintenance. And then whatever they need, they can use it additionally for PRN breakthrough. And if they have to use it frequently, then we go from the, like Symbicort 80, we go to the 160, step them up to step 4 with a higher dose of ICS, and still use the formoterol in the same dose, and still use it for both maintenance BID along with rescue. So step 1 through 4 is one inhaler. Yep. Does that make sense? That's the new guideline. And it turns out that if you do it that way, especially the PRN, you're using less inhaled steroids using that than you are with taking an inhaled steroid every day for maintenance in step 2. Right? You're going to reduce your steroid dose per month if you use it PRN than scheduled. And it's just as effective. It's called smart therapy. And this is your patient with concomitant asthma, COPD. The more asthma-like their disease is, the more they're going to need an inhaled corticosteroid. The more COPD-like it is the likely they're going to need more of the long-acting antimuscarinic tiotropiums, umeclidiniums, and the like, glycopyrrolates. So it depends on where you are, which one you would prefer to use for maintenance. So if it's COPD, you're going to start with a anticholinergic first, and then add a long-acting beta agonist to it. If it's asthma, you're going to start with inhaled corticosteroid, and then add a long-acting beta agonist to it before you add a long-acting antimuscarinic. So it's going to be reversed, the order, depending on which one you use, depending on where they are. And if they're in the middle, you're probably going to use all 3. And that's where you're going to use either Breztri or your Trelegy type drugs that are a combination of all 3. ICS, long-acting antimuscarinic, long-acting beta agonist, all 3 in one inhaler. We'll come back to that in just a minute. This is the new kid. This is albuterol budesonide fixed dose combination. This is the study they published in New England Journal back in 2022. And so we now have a fixed combination metered dose inhaler with albuterol plus budesonide for PRN use. FDA approved January the 10th, AIR Supra combination, and it's by our friends at AstraZeneca, I believe. And it's the combination, it's approved for asthma 18 and above, not for children. Okay, maximum of 6 doses or 12 inhalations in 24-hour period. Don't know what the cost is going to be yet. It'll be branded. And it does appear to work, but it's not going to give you 12-hour duration. So why not use Symbicort or Dulera like the guidelines suggest with ICS formoterol? This would be an alternative down at the bottom, alternative therapy, when you're still using albuterol and you need to use an ICS with it. It's one inhaler instead of using two inhalers. But it's still not as good as what we have with ICS formoterol. Yes?
Are we going to run into issues as far as having to refill earlier? And
Yes, you are. You are. Nope, it's the same inhaler, so we have to be aware that they may run out of it sooner because it's not just the scheduled use, it's also rescue use on top of that. Insurance companies are going to have to move in that direction since that's where the guidelines want us to go. Not all of them have gone there. Some have and some have not. But over time, I think they will, especially as this becomes more widespread. And hopefully within this year, we'll see generic formoterol combination. And at this point, you don't need FDA approval because the guidelines are recommending it independent. Now, in Europe, it's already approved and used for both. It's not here. And I'm not sure that the two manufacturers are going to go after the approval because the formoterol is already off patent. So are those steroids. And if we have a generic of those inhalers, then why should the AstraZeneca or Merck go after the indication to expand the indication? They're not going to pay for it. So it's just like with losartan. Losartan is not FDA approved at the highest dose for heart failure, yet it's in the guidelines. We'll show you that later this morning. So there's some things that are out there that are off-label that we do, but the guidelines recommend it and they're evidence-based. Bisoprolol, we're going to talk about for heart failure. It's not in the guidelines. It's in the guidelines, it's not in the label, because the study was done to show it was safe and effective in heart failure after the drug went off patent. Same with losartan in heart failure. The HEAL trial came out after the drug was already generic, so the manufacturer has to pay the FDA to review the data to get the dosage where the indication changed. So it's all about the dollars, sorry to say. And I wish that weren't the case, especially when it comes to drugs that have good evidence that the company's not going to pay for. The FDA should go ahead and review the data and make the label change on their own. There's talk about it, but it hadn't happened. Yes. Yes, yes.
comments.
Okay. I will try and remember to do that. If not, yell at me and tell me. This is just letting you know that next week is World Asthma Day, and hopefully we'll see an update on the GINA guidelines, see what happens. So that's from their slide, not mine. Same group also gives us the gold guidelines for COPD. And this is the 2023 update. This was updated earlier this year. And there are a couple of major changes in this guideline from 2023. So I've bullet pointed in blue some of the major things I want to review with you. Combination SABA-SAMA is superior to SABA by itself. What's the combination product SABA-SAMA? Got an orange cap Respimat. Combivant. Combivant is the only one of the inhalers that is a SABA-SAMA combination. It is albuterol plus what? Ipratropium bromide, which is the anticholinergic. They're both short-acting, and that is the preferred reliever for patients with a COPD exacerbation. So if they have an exacerbation to relieve it, they want you to use that combination or duonebs with a nebulizer or in the hospital. So typically we're looking at Combivant with the orange cap Respimat is the preferred reliever for COPD, not albuterol or leave albuterol. It's more effective adding the anticholinergic. That's not true for asthma. It is true for COPD. Second bullet point, LAMAs have a greater effect on exacerbation reduction compared with LABAs, level evidence A, and decreased hospitalization, level evidence B. Long-acting antimuscarinics are better than long-acting beta agonists when it comes to maintenance therapy for COPD. So your salmeterol, formoterol drugs are not as good as your tiotropium, umeclidinium, those kind of inhalers, Incruz and Spiriva, which are the two once-a-day long-acting antimuscarinics. Combination LABA-LAMA is better than either alone. So the combination of adding a long-acting beta agonist to a long-acting antimuscarinic is better than either agent alone. So what are those combinations? A neuro, or that's the Anoro. What's the Anoro ellipta look like? It's got the red cap, and it only comes in one strength. There's only one. And what is the green cap ellipta? Incruz is the trade name. It's umeclidinium. It's the long-acting antimuscarinic by itself. They do not have the long-acting LABA by itself in one of those inhalers. You only get in combination with either umeclidinium or with volanterol, which is their once-a-day long-acting beta agonist, or with their combination with their umeclidinium. Only combinations are available with their LABA in the inhaler from GSK. What's the other one that's out there? What do you know about Spiriva? There are 3 different Spirivas on the market. We have 2 different Respimats and the HandiHaler. The HandiHaler is the capsule that you put in and inhale the contents of the capsule. Then you have 2 different Respimats. They both have the same light blue color cap, but one's half the dose of the other. The half dose is for asthma, the full dose is for COPD. So there are 2 different ones you need to look at with Spiriva. They say same name, same color, same Respimat, just a different amount, and you got to check the label to see what they are. They're not easy to tell apart. You need to read the label. And what is the one that's the combination Respimat that has tiotropium plus olodaterol, which are both once a day. One's a LAMA and the other's a LABA. What's that Respimat? Stiolto with the green, bright green cap. That's a once a day LABA as well. So there are only 2 once a day LABA-LAMAs. So the combination is better, and they're listed here. Umeclidinium, volanterol is Anoro, tiotropium, olodaterol is Stiolto. Then you have 2 others that are twice a day. Ultibron and Bevespi are BID, and both of those have different, they have glycopyrrolate in them as their long-acting antimuscarinic that's 12 hours. One has formoterol, the other has indicaterol as their beta agonist. So the only one with formoterol in it is Bevespi. But again, it's not a recommended inhaler for rescue. The rescue is still the Sama-Sama. Combination treatment with LABA-LAMA reduces exacerbation compared to monotherapy, level evidence B. Couple of other bullet points. Inhaled corticosteroids generally are not used. And I'll show you a red, yellow, and green stoplight from the guidelines in just a minute, so I won't dwell on that. They're not as effective, but if they have elevated eosinophils, they have multiple severe exacerbations, you might consider adding an ICS to your LABA-LAMA as a triple therapy, not as first or second line. And very severe with a history of exacerbation, you might consider also adding a oral glucocorticoid for 5 days. 40 milligrams of prednisone a day for 5 days if they're hospitalized with a COPD severe exacerbation. Otherwise, there's no reason to use oral steroids in COPD patients. Here's the stoplight from the friends at the GOLD guidelines. Strongly favors use. History of hospitalization for exacerbation of COPD, especially 2 or more hospitalized exacerbations in the last year. Say you might want to consider adding an inhaled steroid to your therapy. Also, if they have eosinophil levels greater than 300 eosinophils per microliter. So elevated eosinophils suggest they might benefit from adding inhaled steroid, but if they have a history of concomitant asthma, add an inhaled steroid. So those are the times when it's green, and that's when Trelegy or Breztri are the only 2 triple drugs out there. Trelegy has the light beige cap with the inhaler from our friends at GSK. So it's got umeclidinium as the long-acting muscarinic. It's got vilanterol as the beta agonist, has fluticasone feruate as the ICS, all once a day. So it's 1 dose once a day. And then Breztri is twice a day. So that's a BID, triple. Yellow. They had 1 exacerbation, a moderate exacerbation in the last year, and the eosinophil levels are between 100 and less than 300, intermediate. You might consider adding it as a 3rd-line drug. Red, against using it if they've had recurrent pneumonia, because using an inhaled corticosteroid in COPD patients increases the risk of community-acquired pneumonia. So pneumonia risk goes up with ICS, inhaled corticosteroids, in people with COPD. If their eosinophil levels are less than 100, or they have a history of mycobacterial infection, because you could unmask it and re-exacerbate it. So this is the red, yellow, and green stoplight from the World Health Organization, NHLBI, on when you use steroids in people with COPD. 2 studies that looked at triple therapy. The IMPACT trial that used our friends Trelegy and Breztri in the ETHOS trial. And both of those suggest a reduction in morbidity and mortality with triple therapy as compared to dual therapy or individual components of the triple therapy in trials with people with severe COPD, especially those with a history of severe exacerbations and or asthma. So there is good evidence for the triple for selected patients. And here are your 2 triples. This is the Trelegy over here on the other side. See, the labels are the only thing that's really different. You got the blue and white with the 100 microgram and the 200 micrograms fluticasone has got the yellow. The only difference, because the other component, vilanterol and umeclidinium, are the same. And when you come over here to Breztri, it's a meter dose inhaler, and they've changed it a little bit recently. They've actually they've added this tab. It's now a bright yellow canister. This part is bright yellow. It's hard to see on the slide. And you see this. This is the activator when you come down. This is meant to prevent unintentional activation of the inhaler. So as long as this cap is closed, you can't depress it and release the dose. If you were to take this and flip it open like you're supposed to use it, then this is going to be able to go down and you can release it. The old one didn't have this tip on it, so you could actually activate it without intentionally trying to do it. So those are a couple of changes they made, and it does have a counter on the top as well. So that's Breztri, but it's twice a day, and the other one is once a day. They're the only 2 triples on the market right now. And Trelegy can also be used for asthma, where Breztri is only approved for COPD. We'll go ahead and move ahead a couple more. We also have in the pipeline for COPD, Dupixent. This is approved for asthma. It's now being pending approval for COPD. Okay, and it's not approved yet. And it costs about $4,600 per 300 milligram, 4 weeks supply. So you're going to have prior authorization for this one. This is a specialty drug. Okay. And here's the trial that got,
Can I get it?
you get a 3-month supply. No. The answer is no. And it does reduce exacerbations, just like it did for asthma. It's approved for asthma. For this, it's a step 5 drug in asthma, and it looks like it's going to be approved, the first one of the immunotherapies for COPD. And this is the other trial, the Boraz trial. Same thing, it shows it's safe and effective, but it's expensive. So this is the table that changed in the guidelines. Used to have A, B, C, and D. A, B, C, and D. It's now A, B, and E. They've combined C and D into E. This is new in 2023. And basically, these are people, E is greater than 2 or equal to 2 moderate exacerbations or 1 leading to hospitalization per year. And no matter where their symptom score is, if they've got 1 or more exacerbations a year, then they're E. They go to the top of the group. Now, what is the only thing you can do to prevent from going from here to here to here? Anything prevent progression? These drugs don't. They don't affect it at all. They treat the symptoms, reduce exacerbations, but they don't prevent progression. Stopping smoking is the only thing that prevents progression. That's still the #1 thing we need to educate our patients on. They're going to continue to get worse if they don't quit smoking. And there's nothing else we can do about it. It's a progressive disease until you quit smoking. These drugs may help you now, but we're going to have to continue to ratchet them up, and it's not going to slow down the progression. It's still going to progress. We're still going to have to increase the drugs that you need, and you're still going to get worse. So here are their new treatment guidelines. Group A, a bronchodilator. What's the bronchodilator of choice? What did I tell you? No, the bronchodilator of choice for COPD. If you're just using a PRN for rescue, Combivent, Sama, albuterol, ipratropium. Okay? When you go to group B, a LABA plus LAMA combination is better. Remember, the LAMA is better than the LABA, but the combination is better than either one alone. So drugs like Stiolto and Anoro are the 2 preferred because they're both once a day, and the guideline prefers once a day, as long as you can get them covered by your third-party insurer. The guidelines prefer once a day for maintenance for these people, and then they still use Combivent as their rescue. So even though they're on the long-acting antimuscarinic beta agonist, you give a short-acting antimuscarinic, short-acting beta agonist for rescue on top of it. So it doesn't hurt to give albuterol on top of your long-acting beta agonist, and it doesn't hurt to give ipratropium on top of your long-acting antimuscarinic. Bless you. Okay? And then when you go to group 3 or E, LABA-LAMA is still there, and based on symptoms and eosinophils, you might add an ICS on top of that. So that's the progression. Just the reverse of what we see with asthma. Asthma, we start with ICS. ICS is last line here. Asthma, we go to long-acting beta agonist preferred before we go to long-acting antimuscarinic. Here we go to antimuscarinic, especially in combination with a beta agonist, and then add a steroid. Make sense? So that's the new algorithm from the GOLD guidelines from 2023. And then If you're still symptomatic, you can add things like Daliresp, the PDE4 inhibitor. So we've got some other things we can add it that do reduce exacerbations, the oral therapy. And they also still have in the guidelines adding oral azithromycin, but that one is really not something we want to do because we're going to increase resistance. But it's there as an anti-inflammatory because it has anti-inflammatory activity, but it's not preferred. You have an exacerbation, we treat it with the LAVA or LAMA, and again, the combination is better. We can add an ICS, we can add roflumilast, and again, azithromycin, preferably in former smokers, but again, it's at the bottom of the list, and most of the time, we'd rather not do it. Okay, and again, it's the anti-inflammatory activity from that macrolide that we're looking for, not the antimicrobial activity. Oral steroids, the reduced trial was done. It was published in JAMA. In people with exacerbations, severe exacerbation COPD, they compared to 5 days versus 10 days of 40 milligrams of prednisone, and 5 days was as good as 10, and it still reduced the risk of re-exacerbation or readmission. So the recommended dose is 40 milligrams a day for 5 days and then stop. That's the prednisone dose for an acute exacerbation in somebody who's hospitalized. Yep. So what questions do you have for me for COPD or asthma? Yes.
Singular.
Where does Singulair fit in? Singulair montelukast is something that you can use. The problem we have is we don't have any way to predict who's going to respond to it and who's not. The other thing that we have is a new black box warning from the FDA about all types of neuropsychiatric side effects, including suicidal ideation, including dementia, including hallucinations, all kinds of tics, you name it, are there, and they're in spades. So we've seen more and more of those. And so it's not recommended for allergic rhinitis anymore by the FDA because of those adverse events. It's not high on the list in any of these guidelines. Something you could use, but we have no way to predict who's going to respond and who doesn't. And it's not as good as an inhaled steroid for asthma. But a good question. Any other questions on asthma COPD?
Would you repeat that about singular?
Yeah, Singulair is a leukotriene receptor modifier. And what it does in some patients, it reduces the risk of exacerbations of asthma. It's not for COPD, it was for asthma, but is also heavily promoted for allergic rhinitis because it may help that as well. But because of increasing case reports to the FDA of neuropsychiatric side effects, it now has a black box warning, and it also has decreased recommendations for its use. It's generic and it's cheap, but it's no longer being actively recommended as a drug for asthma or especially for allergic rhinitis. And it's hard to predict who's going to respond and who doesn't respond. There's no niche for the drug in asthma patients. If we could predict who it worked in, it might be worth a try, but we can't. And I have a family doctor friend who I met at one of these meetings, and I had a slide at one of the meetings on the black box for Singulair. And he said, my son has been on Singulair for asthma for years, and he is on the spectrum. He's got all types of, he's tried to commit suicide 4 times. He's got, he's hearing things, seeing, he's hallucinating, doing all these things. And he said, I had no idea that could be a side effect from montelukast Singulair. He said, we stopped the drug and about half of those things went away. He came up and gave me a hug. He said, if you hadn't told me that, I wouldn't have known. And, but that's why that black box warning is there, based on those case reports to the FDA. And it is not a great drug from an efficacy standpoint. It's not recommended on any of those guidelines, is it? It's not listed as a preferred first, second, or third line drug. It still can be used, but it's not high on the list. Theophylline is no longer high on the list. There are a lot of things we've used in the past that have gone pretty much by the wayside. Other questions before we move on? Yes.
Particular and obviously this work side effects, if someone, a lot of patients that I see have been on it for years don't have it, if they've been doing well on it for years.
It's not a problem.
And is there certain timelines that,
No. They're all, the case reports are all over the place. People on a long term are just starting, so we have both. But it's the warning to look for those kind of things. So if you see them, then and are on the drug, you need to think about relating it and consider stopping the drug. But if they're on it and they're doing well on it, like I said, some people do great on it, but we can't, there's nothing to predict who's going to do well and who's not going to do well.
Related to this, but I'm curious if the two slides that you skipped earlier on the amoxicillin shortage.
Yeah. Oh, the amoxicillin shortage, it's mainly the suspension. It's in short supply. And so those slides give you what the guidelines recommend from the American Academy of Pediatrics. What are the alternatives to amoxicillin? That's all they are. Okay. But we still have a shortage of lots of different drugs, but amoxicillin is one that we don't think about, but amoxicillin shortage is with us today, the suspension in particular. I don't know how many of you have problems getting amoxicillin suspension in your pharmacies. Hopefully it's something they say was going to be corrected by mid-year, but I haven't heard anything one way or the other. But yeah, that's why, and I skipped it because it's not as big a deal today as it was initially. Should we take another short break? Then we'll talk about heart failure. Thanks, Charlene. Let's take about a 10-minute break and we'll come back and change gears. Huh?
My son is at extended there in fourth grade.
Yeah, as long as they're doing well on it, it's okay. Just be aware that these are side effects that they've seen in multiple people. Yes. So any change in behavior could be a red flag. Excuse me. Diet Coke is-
Yes, I'm taking care of it.
Thank you.
You want to go on the cruise tour?
It doesn't matter.
Up to you.
I may not then.
Okay. All right, I figured you may want to just relax.
Yep.
So.
This takes it out of me now.
You seem like you're happier this year. We're not, but I hope everything's okay.
Yeah, I'm just a little bit slower. I don't have as much energy, but I'm trying to keep it
Aren't
up.
we all?
Yes.
Let me tell
Yep.
you. Did Andy tell you that about his neurological?
Yes. And he's doing boxing now too with a boxing coach.
Yeah, of course, they wouldn't let him.
He doesn't have
Not
Parkinson's.
Study without the diagnosis, but they would, they allowed him to go ahead and do the.
With the coach.
Work with directly with the coach that does that.
That's great.
Yeah,